Hello, my name is Mazampir. I'm going to discuss with you colorectal cancer today. Our presentation will be as follows. I'll start with the introduction, risk factors, clinical manifestation of colorectal cancer, investigations which can be done under colorectal cancer, staging of colorectal cancer, then lastly we'll look at the treatment of colorectal cancer. So, like I said, introduction, colorectal cancer can also be called colon cancer or cancer of large bowel. It includes growths in the colon, rectum, and appendix. So, this cancer, we're saying it includes areas like the colon, the rectum, as well as the appendix. So, let's look at the groups that are at high risk of having colorectal cancer. The first category is people who are above the age of 40 years old. People who are above 40 years old is a risk time for both male and women. So underage as a risk factors, it is cutting across both on men and women. It is not explaining like in men it is more high, or in women it is more high, but anyone who is above 40 can be at least of having this cancer. Then the other risk factor is colorectal polyps. So these colorectal polyps are growths which are mainly found in the colon. So if these growths are too many, they may also predispose someone to have colorectal cancer. Another risk factor is chronic inflammatory bowel disease or ulcerative coli-tis. In ulcerative colitis, the colon undergoes inflammation for a long period of time. So this is also one of the predisposing factors. As the colon undergoes inflammatory process for a long period of time, it becomes prone to colorectal cancer. Also, family history of colorectal cancer or adenomas. There are times when this disease or condition has tried to show itself in families. Many are the times that about 3 or 4 people in one family they've been exposed to colorectal cancer. So, in other words, we're talking of genetic predisposition. The other risk factor is previous history of colorectal cancer. In previous history of colorectal cancer, we're talking of someone who had colorectal cancer before, and for the fact that treatment did take place very well, it could be surgery failed or chemotherapy failed, this cancer can still come back. Then cigarette smoking is also one of the predisposing factors. In cigarette smoking, there's free release of radicals when someone is smoking. The radicals which are being released from cigarette, they intend to change the DNA of an individual. When the DNA of an individual has been changed, anything is possible that an abnormality can be associated with the change of the DNA. And one of it is that someone may present with colorectal cancer. Then obesity, nature of the risk factor currently unknown. So in obesity, we are saying it is not truly known. It is not yet known how obesity predisposes someone to colorectal cancer. However, research has shown that 3/4 of people who are obese, they've also presented with colorectal cancer. We move to clinical manifestations which may be found in someone who has colorectal cancer. The first one is um, there are usually no early symptoms, and the disease is often diagnosed incidentally. So I'm saying in most cases, people who have colorectal cancer, it's not obvious that you are going to know here and there that someone has cancer. It takes time. Their signs and symptoms may just present like any other conditions. Another manifestation is cancer in distal colon and the rectum typically produces symptoms related to partial obstruction. So just like I've said, someone may present with signs and symptoms of obstructions, which could not be the obvious sign that someone has colorectal cancer. Obstruction symptoms can be there in intestinal obstruction, which can be complete or partial. So they may present with other signs and symptoms. So diagnosing that someone has cancer of colon, it's just incidental. The patient may experience a change in bowel habits. The patient may experience a change in bowel habits. Obvious, all of us, we know how many times we normally answer the call of nature. It may be once, maybe twice in a day, but a change in bowel habit, it could be if you've been opening once, maybe in a day you may not open, or maybe if you have been opening it once, you may increase the frequency of opening. So this also tells us that we need to know ourselves how often we open bowels in our in a day. A feeling of incomplete bowel emptying, a feeling of incomplete bowel emptying, it is also one of the predisposing factors. This simply means someone goes to answer a call of nature. It feels like has finished defecating, but within a short period of time, someone still goes back to the toilet, and this is also one of the predisposing factors. Then rectal bleeding, bleeding from the rectum. After defecating, many of the times that we need to take a look at the nature of the stool that is coming out. Is it normal? Is it blood? And if there's blood, this is what we're saying, rectal bleeding. Then constipation or diarrhea. Constipation and diarrhea is also one of the predisposing factors to colorectal cancer. Pencil or ribbon shaped stool, the stool that comes out when someone goes to answer the call of nature, it looks like ribbon or a pencil or a shape of a pencil. We know how a pencil looks like, very small, very small. That's the nature of the stool that comes out. Then fatigue and malaise. These are some of the general signs and symptoms that we mentioned, like someone with colon cancer may still present with fatigue and the malaise, of which is quite common even in other conditions like malaria. Then we have anorexia, anemia, where someone presents with low HB because of chronic bleeding in the GIT. There will also be lot weight and the abdominal pain as some of the clinical manifestations of colon cancer. Let us look at diagnosis. Under colon cancer, one of the investigations that we have to do is digital rectal examination. Under digital rectal examination, the clinician inserts a lubricated finger which is gloved into the rectum and feel for abnormal areas. It only detects tumors large enough to be felt in the distal part of the rectum, but it is useful as initial screening test. Another investigation that can be done is fecal occult blood test, a test for blood in stool, a test for blood in stool. So if there's blood in stool, it will be detected as a sign of colorectal cancer, just like we said in the predisposing factors. Also, endoscopy. Endoscopy can be done to visualize the GIT and see some of the abnormalities which we have discussed earlier on in the predisposing factors like chronic GIT breeding. Also, sigmoidoscopy can be done, and under sigmoidoscopy, a lighted probe is inserted into the rectum and lower abdomen, lower colon to check for polyps and other abnormalities. Apart from sigmoidoscopy, we can also do colonoscopy. A lighted probe called a colonoscopy is inserted in the rectum and the entire colon is visualized for polyps and other abnormalities that may be caused by cancer. So you may see that with sigmoidoscope and colonoscope, you use a lighted probe, which your interest is to visualize any abnormality that the colon or sigmoid colon may be having. Another investigation that can be done is biopsy. Another investigation that can be done is biopsy of the colon or biopsy of the rectum, which can be sent for cytology. So this is one of the pictures which is showing colon cancer. You can see that inside the colon, at one area, there are cancerous cells which can be seen, and it is quite different from the other tissue of the colon, and that is the site where the cancer is. We can also do barium enema with X-ray. We can also do barium enema with X-ray to detect colon cancer. Another investigation that can be done is positron emission tomograph, abbreviated as PET. Positron emission tomograph, abbreviated as PET, is a three-dimensional scanning technology where a radioactive sugar is injected into the patient. The sugar collects in tissues with high metabolic activity, and an image is formed by measuring the emission of radiation from the sugar. So in this investigation, like we know that someone who has cancer, the cancerous cells are quite active, especially when it comes to sharing of nutrition contents. So in colorectal cancer, in these investigations, the sugar collects in tissue with high metabolic rate, and in these tissues with high metabolic rate, it also indicates that in areas where the sugar is going to collect more is the area which is affected with the cancerous cells, because cancerous cells, they get more nutrition contents as compared to other normal cells of the body. We look at staging of cancer. Let's look at staging of cancer. So colon cancer staging is an estimate of the amount of penetration of a particular cancer. It is performed for diagnostic and to determine the best method of treatment. So in the staging of cancer, we are interested to know how far the cancer has gone. If we know how far the cancer has gone, it also gives us an opportunity to select the best method of treatment that we can give to our patient. The system of staging colorectal cancer depends on the extent of local invasion, the degree of lymph node involvement, and whether there is distant metastasis. So just like I've said, we really need to know how far the cancer has gone, because if the cancer has gone as far metastasis, if you just employ surgery without chemotherapy, we may not be able to control the cancer. So we need to to do staging with the aim of knowing how far the cancer has gone. Definitive staging can only be done after surgery has been performed and pathology results reviewed. So we are saying we may be able to stage cancer in relation to local invasion, degree of lymph node involvement, as well as whether distant metastasis has taken place. But we are saying surgery, when surgery has been performed, it can be the best way of staging cancer, because in surgery you open and you actually have a look at the actual cancerous cells to see whether they have advanced or not. And these, they can also be linked to the pathology results for bulbs that we did. So under staging in stage 0, tumor is confined to mucosa. Tumor is confined to mucosa, or in other versions they'll say tumor is in situ. Then in stage 1, tumor invades the submucosa and mascarillas. In stage 1, tumor invades the submucosa and the mascarillas. In stage 3, the tumor invades subserosa or beyond without other organs involved, or invades adjacent organs, or perforates the visceral peritoneum. So in stage 2, we can see that the tumor, which was just in the submucosa and mascarillas, it is now going beyond. But even if it's going beyond, it is not involving other organs. It is just affecting the areas that are surrounding the submucosa and the mascarillas. Then in stage 3, metastasis to regional lymph nodes. So depending on the location of the colorectal cancer, we're saying in stage 3 there will be involvement of lymph nodes. Like for instance, if you look at the abdominal cavity in relation to the pelvic region, the immediate regional lymph nodes that we have are the groin lymph nodes. So if the colon cancer is migrating or is moving to the regional lymph nodes, we're talking lymph nodes of the groin. We're talking the lymph nodes of the groin, because these lymph nodes of the groin are the immediate regional lymph nodes which are closer to the rectum and the colon. In stage 4, there is distant metastasis which is present. In stage 4, there is distant metastasis which is present. So stage 4 is a continuation of stage 3. In stage 3, we said there is involvement of regional lymph nodes. So in stage 4, it means that other regional lymph nodes are involved. What do we mean by other lymph nodes regions? We find lymph nodes in the armpits as well as in the neck. They are there. So these, they'll be now involved. Simply trying to mean that there is a metastasis that has taken place, meaning the cancer has advanced. So that was the staging. Then we look at treatment. We look at treatment after diagnosis has been confirmed. Treatment may be initiated by radiation and chemotherapy. Treatment may be initiated by radiation and chemotherapy. So radiation may be used preoperatively or as a palliative measure for patients with advanced lesions. So I'm saying patients with really advanced lesions of colorectal cancer, they may benefit much from radiation. They may benefit much from radiation. Then chemotherapy is recommended when a patient has a positive lymph node at the time of surgery or has metastatic disease. So under chemotherapy, we are saying when a patient has a positive results from lymph node bulbs, they may They may be linked together with chemotherapy as well as surgery. And in most cases, when the cancer cells go as far as the lymph node, it means metastasis has taken place. Metastasis has taken place. No drug is available that can cure malignant colon or rectal tumors. No drug is available that can cure malignant colon or rectal colon. Surgery is the only curative treatment of colorectal cancer. So we need to understand that surgery is the surest method that can benefit much the patient by having the cancer treated. Success of surgery depends on resection of the tumor with an adequate margin of healthy bowel and resection of the regional lymph nodes. So under this point, we are saying if surgery is to be successful, we need to resect the region which is affected by colorectal cancer, as well as getting rid of lymph nodes which are closer to that region which is affected with the cancer. Apart from surgery, another procedure that can be done is right hemicolectomy. Right hemicolectomy is performed when the cancer is located in the cecum. Right hemicolectomy is performed when the cancer is located in the cecum, ascending colon, hepatic fissure, or transverse colon. So in this procedure, we only perform it when the cancer is affecting any of these regions, like the ascending colon, hepatic fissure, or the transverse colon. So like we've said, none of the options available is so obvious in the management of cancer. In most cases, we combine surgery together with the chemotherapy. So we have come to the end of our presentation.